All right, so I've got a lot of slides for you today, but I'm going to move quickly and try and save questions for Q&A at the end, and we're going to have some questions as we go, a little more than I've done in the past, because I think questions always drive home the point. Once you think about the information, it's easier to keep. So, legal risk mitigation. How do you reduce your risk? How do you use the law on your side when you're having debates with hospitals and other groups, the enemies of price transparency in the system? There's the disclaimer. Some of these slides have lots of words on them. They'll all be posted and available to you later, so don't feel like you need to have to write down every word, especially on some of the larger legalese sections. So what are our goals today? We want to understand how DPC has grown across the United States, what are the motivations for state laws across different states, and then we want to use the HITECH Act to achieve better price transparency. And we want to see about how you can help your patients do that in a variety of settings outside of your practice. And then we're going to get into the often discussed opting out of Medicare issue as well. So how do we define direct primary care? This is what I've listed on the DPC frontier. It came out of several early state laws, and it's sort of the simplest way to legally define it. You're charging a periodic fee that's usually on a monthly basis. You're not billing any third parties on a fee-for-service basis. I call that the no double dipping prohibition. It's what distinguishes DPC from concierge, where they're charging a monthly membership fee for non-covered services, and they're still going ahead and billing insurance or Medicare or whoever it was on a usual coding basis. And then the third part there is to distinguish DPC practices from urgent care practices. There's nothing wrong with cash pay urgent care, but as I'm sure everybody in the room can imagine, if you charge $10 a month and $90 per visit, that's more of a discount urgent care setup than it is something that incentivizes an ongoing relationship with the patient. And also, importantly, that design does not get you unwanted attention from the state insurance commissioner because they don't see risk there. So this definition is not meant to be exclusive. It's meant to protect the practices that need protecting. So does this definition do the following? Does it exclude a hybrid practice? There you go, if you want to vote yes or no. Yeah, good, right? All right, this is working. So that's the second part of it. It looks like we're doing well there, so we'll move on. Is it meant to be exclusive? I spilled the beans. I've said this too many times. We got some better questions later. These are warm-ups. Does it imply that other models are illegal or bad in some way? All right, there we go. Quick answers. Does it consider that an employer might pay the monthly fee? Was that prohibited by this definition? Oh, we got a debate going on here. So it's true that it doesn't consider it, okay, but the issue here is, can they still pay the monthly fee? So this is a poorly worded question by me, and that's good feedback. The employer can absolutely pay the monthly fee. It's not prohibited by this definition. All right, does it distinguish DPC from concierge? All right. Some people agree, some people say maybe not. Okay. The point is, of course, to distinguish the two, and that's why you have the second part of the definition. So the answer should be yes. What did DPC look like in 2014? Back in 2014, I was in my second year of family medicine residency doing some research with the research arm of AAFP in Washington, D.C., and so I started to put together this mapper. We had 125 practices found across the United States, and it's grown by about 200 per year. By 2015, we were up to 290, 2016, 445, 2017, 620, and this was a few weeks ago, we were 840. I think we're above 850 now in the mapper. DPC laws started with West Virginia, had bad law in 2006. Vic Wood up in Wheeling was seeing a lot of uninsured patients and got unwanted attention from the insurance commissioner, had a very narrow carve-out where he was allowed to keep seeing his patients in this manner, but really wasn't allowed to broadly market, wasn't allowed to grow the practice, wasn't allowed to do the things we talk about today. All that has changed. They now have great law on the books, and we're going to kind of roll through this quickly so we have more time for question and answer later. As you can see, there was a gap for a while. Then we had the ACA back in 2012, and then 2014 we got more growth. The ACA referenced Washington State's law, which fortunately was one of the green and better laws at the time, and then we started having lots more efforts. And now we're at the tipping point. We've got 25 states that have DPC law on the books. if you count the purple states that have guidance from an active current insurance commissioner, we're up to 29 that have positive either law or administrative regulation saying this is not insurance. Then we've got a few blue states that are still attempting things in the current legislative session. Arizona's in yellow because their law was an attempt to carve us out of insurance, but really just doesn't do it. It has a bit of a castration clause in it. We can get into that later if anybody wants to. Oregon, their law was kind of modeled after West Virginia, and it's just very restrictive, and it could use some updating. So what happened that prompted these state laws in the first place? We had insurance commissioners that were concerned. They said, you're taking on this panel of patients. As far as I can tell, you're telling them you have unlimited time, you have unlimited services, you're around 24/7, and I can't see a cap on your panel. How in the world can you serve all these people? You're offering unlawful insurance. So a guy by the name of John Muni of AMG up in New York had an insurance commissioner knocking on his door, not liking his contracts. This is before everything was so standardized now, and contracts were admittedly more difficult to read than what we use these days. And what happened there was that ultimately he had to start charging a per visit fee even though he didn't want to. And when he first started charging it, I think it was a bit of a bidding war. We said, all right, fine, $5. No, that's not enough. $10. No, that's not enough. And then they settled on somewhere around $27 or some kind of arbitrary number like that. So silly stuff has happened. There were no criminal charges or anything like that, but it was obviously a hassle for his practice. And then he had that clause in bold there, you can read later, is just an example of what you don't want to do. It starts to look like, when he's got this complicated Appendix 2 and sort of has made things look more like an insurance agreement than they need to be. So here they said that you had unlimited benefits. It was focused on fortuitous events, focusing on urgent care coming any time rather than focusing on ongoing chronic care maintenance, which is really the biggest value in what we do, the biggest cost savings in what we do. Okay. Maryland, what happened there? We had a group of 5 physicians that were about to convert over to DPC back in 2009. They sent out letters to their patients informing them that they were going to convert. One of these patients was related to the insurance commissioner, and it gets sent over to the insurance commissioner. I don't like what my doctors are doing. And then here we go. We get this guidance that was a little bit harsh and sort of spooked them away from doing this conversion. But even in spite of that guidance, if you use standard form agreements that are freely available these days, I've made them available, others have made them available, then you're not going to run afoul of an insurance commissioner problem. So this is there for your reference as well. There was an update from Maryland in 2015. A dental practice was doing what they called a premium plus dental plan. Everybody like that title? That sounds a lot like insurance already. So there's just silly mistakes that people make that make things worse. They use it that offers excellent coverage of XYZ. And so don't use insurance terms. We intentionally don't want to be insurance. When you talk about something covered, non-covered, unlimited, all these are bad buzzwords. South Carolina, we've got a little bit of it's not bad precedent. It's actually sort of a healthy discussion, I would call it. And they went into some details about what you could do to reduce your risk. So I've summarized this in sort of this top 10 reduce your risk suggestions. This is available in a journal Legal Medicine Law Review article that I published a few years ago. So that's something that you want to do anytime you're sort of coming up with your contract. You want to make sure you've considered these things. Okay. So here's another question. Are there any states where DPC is clearly unlawful right now? No is correct. So there's every state in the country you could do this. Some states it's a little trickier than others and requires a little bit more legal homework, just to be careful, but every state it's possible. Are there any states without any DPC practices? Not a single one. All right. So the answer there is yes, North Dakota and South Dakota. For some reason, we're leaving out the Port Dakotas. They've been the last stragglers for a good 2 years now. So since we're in Indiana, let's look at Indiana's definition of direct primary care. They're one of the states that's green and highlighted there. They passed legislation within the past 2 years, and they said it's a contract where a physician agrees to provide primary care health services to an individual patient for agreed upon fee and time, doesn't bill third parties on a fee-for-service basis. Sound familiar? Charges periodic fee for services, and may charge a per visit charge if it's less than the monthly equivalent. So it was a clean and easy definition. If you're in one of the states that doesn't have anything on the books, you want to start with something very simple like this. If you look up Washington's law, it's got some nice provisions in it, but things are more complicated than they need to be. You really can keep this to 1 or 2 paragraphs, and you can keep it budget neutral. And that should get you more votes. Indiana's not insurance provision. Pretty crystal clear there. Even if you're not an attorney, you can understand this. So not only are you not insurance, you don't have to apply for anybody for application or register with any database, which is good. And then they had a few qualifiers. Must meet all the following requirements. These are pretty common. Well, you should write it down. Yes, you should always write down a contract if you want it to be enforceable. Have it signed. You can have the ability to terminate with either party's desire. You should specify the periodic fee and tell them it's for ongoing care, that it's not for the risk of a fortuitous event. So focus on chronic conditions more so than urgent issues. And then state in writing, of course, that it's not health insurance. If they're paying you a year in advance, you need to have the ability to pay that back. They might move after 1 month. If you say, wait a minute, I wanted to take money up front, I don't want everybody to get all their money back, that's not fair to me, I put all this time and effort in up front, then my answer to you is clear this up in your contract. Charge an enrollment fee that's obviously not refundable, and then your monthly fee or your periodic fee, which implies refundability, make sure that it is. To date, most states have not required escrow accounting for this, but it could happen. So you always want to have the ability to pay those things back if you need to. Declining to start the agreement in Indiana, you can't do that solely based on the individual's health status, so you're not supposed to discriminate there. Obviously, if something's outside your scope, you don't have to do that. If you don't do hemodialysis, well, then you don't do hemodialysis. So if they come in for that, you can manage their other chronic conditions, but obviously disclose that to them. Okay, moving right along. If you want to end the agreement in Indiana, you can do that if they fail to pay the fee, if they did some act of fraud, if they're abusive to your staff, and even if they're failing to adhere to the recommended treatment plan, which I think is a pretty broad hat tip to a lot of discretion for physicians. Okay, so we're past the definition point. We get into more of the fun stuff now. So what if you want to send your patient outside of your practice and they either have no insurance or they have a high deductible plan that's really, it's garbage, it's a $7,000 deductible with terrible negotiated rates, they have no desire to use it, they don't have this addiction to meeting their deductible like so many of our patients do. And so they say to you, I want transparent pricing, but this hospital is telling me that it's going to cost me $3,000 for this stress test, and you and I both know that's bogus, and they're demanding that I have to run it through my insurance. And I don't want to run it through my insurance. What do you tell them? So some people used to tell them to lie, say you don't have insurance, hope they don't figure it out, demand a cash price. I don't recommend lying. But I do recommend using high tech. High tech lets you demand, whether the hospital wants to admit it or not, they have to give you a cash price. It might be a lousy one, but they have to give you one under high tech. So high tech was a modification of HIPAA that allows your patients to demand a cash price for privacy purposes. And it doesn't have to be treating an STD. It could be doing anything that's, not necessarily, why would you want that to be private? They can just request it, and they have a right to request it. It's 13405A of high tech. The covered entity must agree to the requested restriction unless the disclosure is otherwise required by law. Okay, so this is for the purpose of carrying out payment and for which the healthcare provider has been paid out of pocket in full. This follows for downstream things. This works at the pharmacy. This works at the physical therapist. You have a little bit of a logistical issue on your part because anytime a patient makes this request of you, so for those of you in the room who are debating converting to DPC and you're in a hospital-owned practice, this could apply to you now. And when a patient makes this request, you have to have the ability to carve this out of the rest of the record, right? Because this is not shared the same way everything else is under HIPAA. So if you put it in your regular medical record and then you get some HIPAA request and you do what you always do, which is send over the info, now you've violated high tech. So you have to silo this off in the record. If you're sending them to a pharmacy, I don't know what you do in the state of New York, because in New York you have to do electronic prescribing, and they're probably going to default that and try and run it through the plan. But what everybody else does is you write it on paper so that the patient can walk up to the pharmacist with the paper prescription and say, this is what it is, and under high-tech I demand cash pay for privacy. Okay. So how does this affect HMO? How does this affect Medicaid? Unfortunately, there was a castration clause in the HITECH Act that said, hey, if we, by the way, if we conflict with another law, that other law is going to win. Okay, so your Medicaid patients could well be left out, and your HMO patients could, because there's no exception for procedure for individuals wishing to pay out of pocket under those categories. What about Medicare? HITECH did contemplate Medicare, and actually Medicare patients can pursue this. Okay, so even a Medicare patient can use this to achieve price transparency throughout the rest of the system. Hypothetically, could you see Medicare patients under private contract without opting out using this provision? Hypothetically, yes. But for those who think they found some nice opted out exception, which we're going to get to later, I would say no. The reason being, you're still limited to the fee-for-service price. So you don't come up with a new price, you're charging them the same Medicare rate for that thing, and you have the same coding obligation for that thing in the event of a Medicare audit eventually. So it gets them a cash price. I don't see very many Medicare patients demanding this. Obviously, it's a little bit of a hypothetical because they're already covered. It's already sort of a low deductible plan, if you will. Okay. That I think I already jumped ahead on. You want to be able to flag this so that you don't share the information with the rest of the health plan. So, in summary, all covered entities must have a process for this, and the refusal must be of the patient's own free will. You shouldn't really be prompting the patient on this. You might advertise your practice based on increased privacy or something like that, but the patient needs to make this request on their own. So obviously nobody has a national ad campaign, so there's not a lot of requests about this, but they need to do that, and they need to sign it. Medicare, Medicaid, we already talked about. HMO, we already talked about. And of course, the people who hate this the most, and this is where it's the most fun, are the private insurance companies. And they may yell and scream at the radiology group or the hospital where you got this price, but there's nothing they can do about it. Because even though they have a contract with that entity, and that group may have promised that they would always report anybody who was under their insurance policy and bill it under that claim, federal law trumps private contract. So too bad. I think it's frozen. Are we good? Okay. High-tech Medicare opt-out implications. Continue to be a participating physician. It still applies to you. Could attempt to charge all Medicare patients privately for covered services. I sort of got into that earlier. That's a little bit complicated, so bring it up again in Q&A if you want to dig into it. It would be very suspect if every single one of your patients was demanding cash pay for privacy, and it also doesn't really get you a new price, so I don't really recommend doing it. Okay. Opted out moonlighting. So if you do opt out of Medicare, so that you can privately contract with patients for covered services, that's a phrase that might be worth writing down, privately contract for covered services. That's the only reason to opt out of Medicare. Because if you don't want to see Medicare patients, you just don't see Medicare patients. The least likely physician to opt out of Medicare is a pediatrician, because they don't have them anyway. The only reason to opt out is so that you can see them under private contract. If you decided to do that because you want to take Medicare patients in your DPC model and do it under private contract, then you are opted out. And you're opted out for 2 years, unless within the first 90 days of it you raise your hand and say, oops, I made a mistake. And then on a rolling 2-year basis, if you so choose, you can raise your hand and say, I'd like back into Medicare. Okay? So if you decide to opt out, it can become a hurdle to getting jobs outside, obviously, because everybody else in the system is taking Medicare. Where do you look for this work? Occupational medicine, urgent care issues, emergency care exceptions we'll get into. Occupational medicine is different. It's usually a state law-based system, and they have a separate payment process for that. Cash pay telemedicine obviously is a possibility. Hospice administration, yes, they work with Medicare, but if you're doing purely administrative role, then you're not billing Medicare, so that works. There's some other interesting programs here. One is called PACE, program for all-inclusive care of the elderly. It's been around a couple decades, and it's the closest thing I can find that the government's ever done to something like DPC. And they're taking Medicare, Medicaid, dual-eligible patients that are this close to going into a nursing home, and they're trying to find a way to keep them at home by giving them broader scope primary care. They don't do any coding, much longer visits, so it's similar to DPC. On-site DPC with a large employer is an option. There are some vendors here related to that today that would offer you a job. And then you can do what I do, which is correctional medicine. It doesn't matter what the patient had. It doesn't matter if they were filthy rich from whatever they might have been doing prior to coming to prison. They can't use that money now. And they don't use whatever coverage they had. It's all Eighth Amendment right to care. And we have much longer visits, no coding obligations, that kind of thing. It's on-site DPC. Okay. So the urgent and emergency exception is the one that gets a lot of attention, and I will tell you, unfortunately, it's not used much. It's difficult to get a hospital system to play ball. I've emailed several of them about this. Most of them don't want to talk to me. The ones that do talk to me look it up, and they usually say, you're right, and we don't care, because this is a burden. We don't want administrative burdens, which I find really ironic. They don't want to code it this way. So they say a payment may be made to Medicare in this situation as long as you don't already have a private contract with this patient. So if you work in a small town, really rural hospital, that could be an issue, because if one of your DPC patients shows up while you're covering the ER, then you can still see them, but you're not going to charge anything for your service at that particular visit. Hospital would still get paid even though you're opted out, because when you're opted out of Medicare, you're still credentialed with Medicare. Hospital still gets paid for all of your orders, but they also want to get paid for your 99213, right? So if they're going to get paid for your 99213 and you're opted out, the patient you see needs to be somebody you have no DPC relationship with, okay? And the other presumption, the other side of this coin, part of the reason this exists, is because this is presumed to be a time of duress, okay? So in law, duress means patient is under some kind of stress, and somebody who's under duress is in no position to sign a new contract, right? If you open your DPC clinic and day number 1, somebody comes in with crushing substernal chest pain, you say, wait a minute, we got to go over this contract. It's going to take about 20 minutes, and then we can get your EKG going, right? That's not a good time to have these conversations. It's obviously unenforceable. You don't want to sign that agreement during an emergency. So the converse is also true. If we're not going to let you sign a private contract during an emergency, we're going to give you the ability to go ahead and bill Medicare for that emergency, because Medicare wants you to see those patients. And when you do it, you use a JG modifier code, and you get paid at the non-participating rate. So there are really 3 Medicare categories. I don't spend much time on the middle one because it really doesn't help most folks here. There's participating, which is what everybody's defaulted to. There's non-participating, where you get paid 95% the rate of Medicare and you have flexibility to bill an additional 15%. Whatever. It's all fee-for-service still. Or there's opted out, where you have the ability to privately contract. Okay. So what's going on with some of the Medicaid pilots you might have heard about? This slide's a little bit messy, and there are probably a whole lot more orange states. They're just hard to find. So Medicaid, there are 2 states that I want to highlight here that are red: Kentucky and Colorado. The reason they're red is because they're doing some very bizarre things. If you're a Medicaid patient in that state, then you can't be seen under private contract, full stop. Doesn't matter if it's DPC, doesn't matter if it's cash pay fee for service, you can't do it. The only way to try and make an argument is you could say I'm seeing them for non-covered services that Medicaid doesn't provide, but the idea that you're running a practice where you're exclusively doing things that are not covered and not coded in any way, shape, or form, everybody knows in this room that's going to be a really weak argument in court. Because the minute you do something that is covered, they're going to get you. So in those 2 states, until they change the Kentucky's an executive order, which you would hope the current governor would reverse, but he has yet to do that. In Colorado, it's actually in statute, so they'd need to change things. It's not just up to the governor. And the other interesting thing in Colorado, it has a little purple square in it, because while simultaneously prohibiting Medicaid patients from privately contracting and receiving direct primary care, they also have a pilot for their state employees to have direct primary care. So figure that one out. In Michigan, they've passed a state Medicaid pilot. It has yet to be enacted and really started, but they've passed it. There are several other states with intent, and Nebraska is doing some interesting things too. New Jersey has a state employee pilot that you might have heard about as well. So all these things, hopefully, if they don't have the same mishaps that Erica Bliss of Q Alliance described earlier, if they're done right, maybe we'll get some good data. The traditional standalone DPC practice that takes on patients one at a time. Some people in the room might be analyzing this at the highest level and saying, what are we really doing here? This is just capitation all over again. How is this different? And my elevator response is, this is a selected marriage, right? DPC patient is picking the DPC physician. If they don't like you, they fire you, right? Nobody told them to go there. And the more we work with employers, especially larger employers, the more you do Medicaid pilots, you have to be real careful that you don't go back to the old arranged marriage of capitation and that you preserve those qualities that made DPC work. So ideally, that's quite a bit of choice. You can do that within larger Medicaid pilots, obviously, where there's 10, 20 physicians participating and lots of places to go. Okay. So there's sort of another summary of things that are similar to DPC but not quite. So the things in green you've got in common with it. And then the red part, I kind of spilled the beans on already. There's some issues when you do that. I tend to get one slide ahead of myself. All right, we got another question coming up here. If an insurance company demands a prior authorization, can you charge them to do it? It's their paperwork, right? Can I charge them? Can I bill them for this? Wow, moving around. I'm going to wait a minute here. I heard somebody say charge the patient. You can charge the insurance company. There's actually legal precedent for it. Gary Gibson v. Medco. He got fed up with them, took him to court, and he won. I don't think they showed up, but he still won. I don't know if he got paid either, but he won. So he proved in that case that this was purely an administrative burden. He was purely doing their paperwork, which they should already have had access to, that it had no clinical relevance to the patient. And so you actually can charge them for that. The physician who brought this up at a different conference I was at, he keeps a copy of that case. And if he gets a prior auth, he sticks a copy of that case on it and writes, I'm not doing this, faxes it back. And most of them get approved. So if everybody would start doing that, we'd start having a lot less prior auths. If I change from a hospital-employed physician to an independent DPC physician, then what's going to happen with my non-compete? All right. So that's the last one. Any of the above, depends on your state law. So I've highlighted a few there that are maybe worth noting. If you're from these states, you might want to take a quick note and look that up for reference. If you're in California, Montana, North Dakota, South Dakota, Delaware, or Massachusetts, that non-competes for show, totally unenforceable. Full stop. Okay? Several other states, you've got restrictive statutes in place, and then a few, you've got some clear favoritism. When you're doing a non-compete, oh, there's a second slide on it there too. We'll get back to that later if we need to. Individual patient asks if she can use her health savings account to pay your membership fees. We have talked about this a lot today. Ask your accountant. That's what you should tell them for now. It's true that Treasury views this as a negative. They don't want you to do it. A lot of accountants take an independent viewpoint that it can be done. And the shortest answer is that it's unlitigated, right? So Treasury thinks they know, but they don't. They haven't tested it in court. Nobody has. And they've also said they don't have a lot of appetite to test it in court either. So the safest, fastest, quickest answer is really to ask your accountant. I'm happy if you want to refer the patients to the tax page of DPC Frontier or to the DPC Coalition. Any of those things are fine. But the truth is that's probably way too much of a debate, and it's not something you want to burden your patients with. So they'll get a quick answer from their accountant, and that's what you can do for now. Large employer, HR director says, can the employees use the HSA to pay the membership fee? And here your answer, would it be the same? Would it be different? So keep in mind, the first question was an individual patient, and now you've got an HR person. Maybe with an attorney even. These are kind of tricky questions. Here it changes a little bit, right? It was ask your accountant because you had the individual patient. When you have somebody with all kinds of legal resources that can do this homework and is really concerned about it, ask your accountant isn't really necessarily the wrong answer, but you do want to steer them in the right direction. If they try and invent the wheel here, then their legal work stacks up much higher. They spend a lot more time on it. If you point them in the right direction where we've already put these resources out there, they can get an answer quicker. The quicker you get an answer from them, the quicker you might be working with them. Will you code my visit today so that I can submit it toward my insurance deductible? Okay. Top two answers are obviously in the right ballpark. The second one's even better. I think it's nicer to say that to the patient than to tell them they might be wasting your time too. But it's also legally more accurate. It's easy to wind up with insurance fraud when you do those kinds of things, unless you want to code every single visit and then somehow try and correlate that back to the monthly fee, which becomes complicated and obviously self-defeating. If I opt out of Medicare and I don't bill Medicaid, then I am no longer subject to which of these laws? This is you, the physician. Good. People are doing well. False Claims Act, which should probably intimidate you just as much as medical malpractice or any number of other fears you might have on the legal side. False Claims Act says that for any false claim to the government, doing a wrong code, overcharging for a certain procedure, they can fine you not only for the amount of the procedure, they can triple the price that they would have paid you, and they can add on like around $11,000 per claim. And when most people make a mistake, they don't do it once, right? They do it over and over and over, because whatever their habit is whatever their habit is. And that's why if you want to look up the legal lottery in this country and retire to Hawaii, one of the best ways to do it is a key tam provision under the False Claims Act, which means if you're the whistleblower that says XYZ hospital or XYZ whatever other large group is doing this wrong, when the government gets $500 million from them in a False Claims Act case, you get 10 to 15% for raising your hand and saying, look over here. So it's one of the best lotteries we have, and it's a reason to be sort of a bit fearful about being involved in that, especially when there are so many other people that have their hands in your billing and coding, quite frankly, who are supposedly helping you, but at the end of the day, it's your license, it's your name that's there. If I opt out of Medicare, then I will no longer be able to do which of the following? Keep in mind it says no longer. Good. Be able to participate in TRICARE. So TRICARE is military, And part of their default contract says that you have to be participating in Medicare to see patients in TRICARE. Technically, they would have the ability to change that on their own administratively, but to my knowledge, nobody's really bringing it up and they don't have a lot of appetite to it. So once you opt out of Medicare, you're still credentialed with Medicare. You can prove that. You can look up that you have a PACOS number. If a physical therapy group or somebody else doesn't want to follow your orders, you can report them. You can report the MAC, the Medicare Audit Contractor, because you still have MPI, you still have PACOS, and you're still credentialed. People confuse opt out with kicked out. They're very different things. All right. And this one I've got an update for just from this conference, actually. So I got to change my own answer here, but we'll still do this. Okay, good. So correctional medicine was my original answer. IHS sounds like it'd be an exception, but it's not. And the VA, I historically thought, was also in the same category as IHS, but that might, there's indications it might not be true. I went back and double-checked the regs, and from what I'm reading, it's still true. The problem with IHS and VA is that they tend to secondarily bill Medicare. So while they're a separate system, they have the ability to go over there and take money out of that pot if and when they so choose. And so doing that means that if you've opted out, they typically don't want you to fill those roles. The other one I hear a lot, get a lot of emails about, hey, I've opted out, but this guy who has his own practice, he says they got their group NPI and they can just bill under that number. Nobody will be the wiser. This will work, right? No, you can't do that. You promised you wouldn't do that in the contract, and I could point you to the Medicare Provider Manual where they make that pretty clear. Can you do it and will you get caught are two different questions. If they're billing under that other NPI, I don't know how quickly they'll catch you, but they may catch you 5 years down the road. I just would not recommend it. Okay, so I went through it pretty quickly. Hopefully we've got some time for questions here.
When you answer the question, just hit the X and it'll go away.
Okay. Good. All right, here we go. Up to the top of the list here. For those who contract with employers, is there legal risk to the patient, employer, and the provider when patients do not file workers' comp and come to DPC? Okay, so a good question. When it comes to workers' compensation, there's going to be some state law variances there. And some DPC practices have been specifically asked by the state workers' comp entity to ghost claim. Essentially say, even if we didn't charge you anything, they want this reported as an injury that happened at work, and they want to be able to track it that way. So I think that's really the extent of your obligation in some places is, do you want to ghost claim or not, and are they going to make you do that? And then you have your second decision point is, do I want to work this into the monthly fee as an additional service offering, or do I somehow want to silo this off and charge some separate amount, whether it's cash pay fee for service, whether it's a different monthly fee if it's workers' comp only. What does it mean if your state doesn't have a DPC law? It means they haven't addressed it. It means you got to go to your insurance code and look up their definition of insurance and make sure you don't somehow get put in that box. The second step is you look up HMO law. Why? Because there are some places where, weirdly enough, DPC looks a little bit like an HMO, which everybody in this room would find incredibly ironic. There are also states like New York City where typically you're not allowed to do some of the things that DPC practices like to do to save patients money. Two most important ones being dispense medications. It's one of 5 states where you can't dispense. Texas, Utah with limited exceptions. And there's a few others I'm blanking on off the top of my head, but I can pull those up. You're not allowed to dispense medications. So back to New York, the other thing they do is you can't actually pass through transparent labs at a discount either. They don't like that. But if you register in New York as a limited service HMO, guess what you can start doing? The 2 things I just said you couldn't. So there's these weird quirks. Most states you don't have to go that far and look at these things in that level of detail. But you're going to want to start at the insurance code, start with HMO law, make sure you somehow don't fit in those boxes. And the vast majority of the time you won't, and it won't be an issue. There's a model contract you can borrow too. Okay. Would you recommend incorporating it as an LLC, but S Corp for taxation? That's a smart question. Yes, that's commonly used. Depending on your state, there are some states where the LLC fees are higher than the S Corp fees. I think Pennsylvania is an example there, so people often start with an S Corp there. Most states you want to do an LLC or a PLLC. And a lot of states, the malpractice provisions and your protections from the LLC I'll rephrase. The protection you get, the asset protection you get from the LLC only applies usually if you have medical malpractice insurance. And then you've got other states like West Virginia where they have a medical malpractice non-economic damages cap, which is nice, but the only time that applies is when you purchased malpractice insurance. So some people that go into DPC say, hey, my risk is lower, I can't get a good med mal rate, I'm just going to go bare and ditch it. That's your call, but look into these laws before you make that decision, and you probably ought to talk to an independent medical malpractice broker that knows something about direct primary care. Because if nothing else, even if they don't think you're necessarily doing a better job, they don't believe you that you're spending more time with your patients, you can tell them, hey, the most people I'm seeing is 600. And I used to see 2,500, right? So that's a lot fewer potential plaintiffs, so your risk should be much lower based just on that. Instead of unlimited, what should the wording be? Oh, I'm not a marketer. Focus on chronic care, focus on an ongoing relationship, focus on your response time. You know, we respond to phone calls within so much time. We respond to emails so quickly. I wouldn't say 24/7, especially if you're a true solo physician, right? A lot of you flew to this conference. I imagine they couldn't call you in the airplane. I know that sounds stupid for me to say, but it'll be enforced against you. The way you advertise gets enforced against you just like if it's in your contract. So don't give somebody that ammunition. If you say you're doing better quality care, be prepared for that to be quoted in the courtroom. And you're going to try and argue this was standard of care, right? You don't want to go in there trying to say you already met this higher bar. You're going to try and say you met standard of care. So when you advertise, it can be used against you, so pick your words carefully. How do you deal with referrals to patients who have an HMO? Publicly, if possible. So when you sign a contract with an HMO, part of that contract says you're going to keep your mouth shut. Now, you're already obligated to do that under HIPAA, assuming the patient doesn't want you to talk about their condition, their need, their whatever. But if you're seeing an HMO patient out of network, and they're seeing you because obviously they can't get good care, can't get affordable care in network, then they're probably already not happy with this HMO. So if they fall off their bike, they need a head CT, they have a headache, you have several options. You could try to order that with your transparent pricing down the street for $300 rather than having to spend $2,000 or whatever and having it not even go near their deductible. And if the HMO declines all this, then you could try your high-tech approach, cash pay for price transparency. Even if they signed a contract, maybe that'll get it through. If that doesn't get it through, you can send them to the ER, which your patient won't like, but then your HMO gets tagged with a big bill at least. Or my favorite option, if the patient wants to, you can go public. Call the news. 55-year-old grandma falls off bicycle, can't get head CT, she feels terrible. You can make this HMO look as big and bad as they're behaving because they don't have any right, they don't have any contractual right to stop you from doing that. Okay, so if you go public, they look pretty bad pretty fast. But to the heart of that question, is the HMO legally allowed to discriminate against you for being out of network in that fashion and not follow you orders? The answer is yes. And this will happen some states with Medicaid, actually. It's a little bit dicey. There were some changes under the Affordable Care Act when it comes to Medicaid credentialing. So one thing I kind of glossed over earlier, when it comes to Medicare, you can opt out so that you privately contract with patients. When it comes to Medicaid, there is no opted out. So Medicare defaults everybody into participating status. Medicaid, you're not defaulted anywhere. Until you sign up with them, they don't know you exist. You're not credentialed. You're not known. So until you sign up, at least after the ACA provisions went in place, then they might not follow your orders, and it might appear to you as if you're dealing with some HMO again. So the answer to that is complicated, unfortunately. Depending on what your state has done. Ideally, they have something called ordering, referring, and prescribing only status. Texas is a good example. There are about 10 others I'm aware of, hopefully more. The ACA told them all to do this, but I haven't found forms in every state indicating they know what they're doing. But you can sign up in that manner, and it basically gets you the same thing as the opt-out does. You can privately contract. They know you're never going to bill them, but they've credentialed you and made sure you're not crazy and you still have your license. If your state doesn't have that, then it's an open question as to what to do. A lot of folks don't sign up, and then in the event they need an order placed, then they have the patient's physician in the system do whatever that needs to be, and they send them a letter and try and get them to order it. Your other option is to, in some cases, if your law is nebulous, kind of like Wyoming, it's a little bit unclear, you can sign up and then still make the argument that you have a right to privately contract within your state's Medicaid provider manual. Okay. If I do work in an urgent care that takes Medicare, Medicaid, and I have DPC, do I have to take Medicare at my private DPC? Okay, so you're doing work in an urgent care, standard medicine. No is the answer. So this is a common way to start, right? So you're wanting to get your DPC practice up and going, and you want to be able to work elsewhere. And to work elsewhere in the system, you're signed up, you're fully credentialed, you're fully participating with Medicare, Medicaid. What does that mean for your private office? For your private DPC practice, then you can't take a Medicare patient, right? Because you haven't opted out, so you can't see them for covered services. Now, you could do what the concierge guys do. You could charge them a monthly fee for non-covered services. But remember, when you do that, my legal opinion is that you're obligated to also bill them on a fee-for-service basis. Why? Because if you don't, then you have to argue to the government with a straight face that everything you did for this monthly fee was something they don't cover. So it's kind of easy to make an argument that, yeah, I had a newsletter and I had a monthly wellness exam, right? Because now they have an annual wellness exam they pay for, so up it to monthly or something too frequent, and say that was a non-covered service. But if you're going to tell them that, hey, everything I did was non-covered, they're going to say, what about the EKG you did last Tuesday, right? What about the osteopathic manipulation you did 3 months ago? Those are covered services. How'd you charge for that? So that can be used against you that way, and I don't recommend doing that. Can you bill the employer if a patient signs up but the patient is not seen? Or do you have to wait for the patient to be seen to begin billing? Good question. Especially with some of the membership management platforms that you guys will see here today, a lot of them promote this online sign-up, right? Patient signs up, patient gives you the credit card info, you start collecting your fee that day. So what I would say to you is, what if they come in your office 2 months later wanting you to refill their methadone? What do you do now? You've already got a patient relationship. You've taken their money for 2 months. You might not even have the ability to prescribe that medication. But you have a patient abandonment issue on your hands. You can try and refund them. You still have a patient abandonment issue. So I don't recommend establishing that relationship by taking the money until you're sure you want to establish that relationship and you're sure it makes sense for both of you. And I don't care if they're coming in from an employer. I don't care how they're being assigned to you. You want to have this upfront conversation where you go over everything. I've worked with large employers as well. We still have an individual patient contract. We still describe to them what DPC is. And under COBRA, even if they get fired from that employer, if we'd accepted them into the practice, even if it's on site, they have a right to come back in there and keep coming to the practice for at least 18 months. So we have to be able to charge them individually for that. So you want to have the same conversation no matter who's paying the fee, no matter how they're joining the practice. You need to have this upfront discussion about what the expectations are, or you can get yourself in trouble. What if you give a year subscription discount but charge $1,000 for a subscription? So charge $100 a visit but charge $1,000 for a year subscription. I don't know. You'd have to ask your insurance commissioner. I think that's waving a red flag in front of a bull a little bit, just to see what happens. There are better ways to do this. If you want money up front, use an enrollment fee. If you're afraid they're going to leave and come back, have an even higher re-enrollment fee. Tell them the practice is near full. You might be on a wait list. Ask around. Folks that have been doing this a while, oftentimes the biggest growth point is when they decide they have a wait list. Everybody wants to get on it, right? There's this exclusivity thing we have in society. So I wouldn't try to charge the year up front and the $100 per visit fee. What that does make me think of, which I'll digress onto for a minute, coming back to the HSA issue that we've discussed repeatedly, currently the IRS has no problem with cash pay fee for service. People forget that. They look at DPC, they see the monthly membership fee, they turn it into a complicated plan. But if you can do what you're doing, if you can provide the level of care you want to provide, and do it in an agreement that looks like cash pay fee for service enough to the IRS, you've solved the problem as is. Now we want to make this change because this conversation comes up and it gets complicated and it takes me hours to discuss, let alone everybody else who hasn't read things to this level of detail. But if you have someone who is interested in it and who's not, super risk averse, then what you do is you might bill them on a quarterly basis and mimic the global surgery fee, right? Because Medicare even covers that, and that's still viewed as cash pay fee for service. So I'll finish off the analogy here. Patient has a laparoscopic cholecystectomy. Things are going well. Post-op visit number 1, post-op visit number 2, post-op visit number 3. Oh, oops, there's an abscess. We got to go back in and drain that. Medicare views that as a surgical problem, right? They view it as a complication. So under the global surgery payment scheme, if they were doing that, within the first 90 days, if there's a complication, there's no additional payment. Surgeon got paid up front. They didn't get paid for those follow-ups. Those were expected. And they don't get paid for the surgical complication where they have to go back in and deal with it, right? You don't want to reward a mistake. So that was the logic behind those laws. And if you try to mirror that in your DPC operation, then you've lowered the HSA risk quite a bit. But having this conversation is complicated, so you have to decide when it's worth having this conversation. You could take the 3 months payment at one time, and then for anything related to that chronic care condition you treated for the next 90 days, you're not going to charge them again. So there are ways to make it look better and to reduce that. Are DPC docs required to fill prior authorizations for medications that patients want to use their insurance for? No, you're not required to. And I wouldn't obligate yourself to do that in your contract. That's up to what you and your patient agree to. If it's a prior authorization for Harvoni, it's probably worth it. If it's for loratadine, no, I'm not doing that. Right? If it's something cheap, they probably ought to be getting it dispensed in your practice unless you're in one of the states that doesn't do any dispensing. So you have to decide when and if it's worth your time and how you want to go about it. Okay. What legal pitfalls should we be aware of for hybrid traditional practices? Okay. When it comes to hybrid practices, the most common question I get is, how do I mess with the insurance companies? And by that I mean, they want to be able to have one arm over here that's contracted with the insurance company and still keep doing fee-for-service, but at the same time give this same cohort of patients the option to be in the DPC arm. How do you do that? You have an LLC agreement with the insurance company on side 1, and you have a separate LLC that has no contract with the insurance company on side number 2. Where do you get in trouble? If you had an agreement with the insurance company where the agreement was at the physician level or the nurse practitioner level rather than the LLC level. You follow me? No, I'll do it again. I need a whiteboard, but if you have, so you can start it with one entity, okay? Let's go back to square one. Your practice is set up as an LLC. You can contract with insurance companies at the LLC level or at the individual Dr. Smith level, right? If that contract with the insurance company is at the LLC level, then Dr. Smith has the flexibility to work in this practice and to work in this practice over here. And when Dr. Smith is in the second practice, that contract doesn't apply to him. This happens now, right? There are plenty of people in the room that work at one urgent care 2 days a week. They work at a hospital 2 other days a week. They work at a third urgent care 2 hours out of town the third day of the week. And they're probably seeing Blue Cross patients at all those places, and they're getting paid who knows what rates based on who knows what the contract was with each of those entities. So there wasn't an individual physician contract signed with Blue Cross in any of those circumstances, right? They were all entity-level contracts. So if the contracts are at the entity level, the physician within them has the ability to plug and play and go various places. That's with insurance. That doesn't work with Medicaid, doesn't work with Medicare. So if you're running a hybrid practice and you want the ability to do this, you can play games with the insurance companies using different LLCs and contract schemes, but it won't help you when it comes to Medicare or Medicaid. The other thing you want to be wary of with running a hybrid practice, of course, are just the business issues. Your overhead's not going to fall. You're going to have the same staff and employees. You're going to have the ability to say to one patient, you get 30 minutes of my time. Patient number 2, you get 7. I think that's hard to do. I think it's hard to turn your brain on and off like that. So I've had prior lectures that have offended some people, but in some sense I call it the facade of hybrid safety. Because people think that's an easy way to dip their foot in the water, and that's probably the highest number of failed practices I see in the mapper. I'd argue they never gave it a go. They claimed to be DPC. They were really a hybrid that never had more than 5% of their patients doing DPC, and they never really did it. So if you want to hedge. Please keep working. Please keep doing something somewhere else. But I think the hybrid is one of the harder ways to get it off the ground. It's easier to keep your foot in a regular practice and then have something totally separate and independent over here that you can slowly grow and ditch what you're doing here. The most common way to do that is to keep working for whoever, have your own thing on the side, build it up and slowly increase the volume, have a wait list for Medicare, right? Because you didn't opt out of Medicare right away to do this. And when you got 300 patients of your own and 50 on a Medicare wait list, then it makes sense to take the jump, right? Then you can opt out and you have all these patients. And you're never creating a cash flow problem.
All right, thank you, Dr. Eskew. Oh wait, one question. On the spot, no.
Okay.
So if a practice is not on the mapper and they would like to be, knowing that a lot of us reference the mapper for how many DPC practices are out there, should they just email you directly?
They can email me, but on the mapper page, there's actually a link they can use to just sign up. Yeah.
Yeah, because I know we use that a lot, and I know a lot of other people do. So please feel free to let Phil know. All right, thank you, Phil.